We'll go to the next case, Dr. Vineet Shukla.
First of all, I'd like to thank NIC organizers and judges for selecting this case for this session. So mine is not very exotic interventional case. It is basically the how to assess the side branch, so-called optical side branch pinching in a provisional stent strategy. So how should we react for this pinching? So mine is a 52 years old gentleman, and in fact he came with acute enterovolumai cardiogenic shock, and he was in cardiorespiratory arrest with ventricular arrhythmias. So he was intubated, and initially thrombosection was done, and he was put on IBP, and then he was shifted to coronary care unit, and this procedure was done after 48 hours. So he was on GP2B, and then he was taken for the procedure again. And this was the angio on the repeat procedure after 48 hours. So patient was on IBP, and this is the angio which shows a significant distal LM which is extending the lesion into proximal mid LAD, and a circumflex which is dominant circumflex. The RCA was non-dominant. So this was the angio, and so we decided we'll go with image-guided LMCA to LAD stenting, and we did initially a 2 millimeter balloon dilatation, and we did a OCT, and this was the OCT, the pullback of the OCT. The LAD was, it was mainly a fibrolipidic plaque, and distal LAD was almost around 3. The proximal LAD was around 3.5. The LM was around 4, and the tightest lesion was around 1.5 millimeter. It was a fibrolipidic plate with some amount of white thrombus here. So initially we took a distal stent, and the stent was around 3 into 38 Zions Alpine Des. So this was the distal stent, and the proximal stent was 3.5 into 23. That was from ostial LMCA to LAD overlapping with the distal stent. And this is the angio when we took after implanting these two stents starting from LM to LAD. And this is the circumflex, ostial circumflex. It looks optically definitely pinched. So how do we react now? Shall we go ahead and convert into dual stent strategy, or we should do something for this ostial, so-called ostial circumflex pinching? So we decided the patient was hemodynamically stable by the time he was fully conscious, and there was no hemodynamic compromise with this ostial LCX pinching. So we decided we'll initially assess this LCX, but before that we just post-dilated the distal LAD stent with 3 mm NC, and the proximal LAD stent with 3.5 NC, and we did a pot, and then we put a physiology wire. We did a RFR, and this was the RFR. It was in fact non-significant. The RFR was 0.96. The contrast FFR was also done. That was around 0.94. The limit, the cutoff limit is 0.83 for contrast FFR. And then we did a pullback OCT from LAD to LM, and also from LCX also. So the stent was, there was minor malapposition. There was no stent edge problems. There was no geographic miss. So there was some minor malapposition. Otherwise, the stent was okay. But definitely there was some hanging struts in the front of the LCX ostium, which was seen in the pullback from the LAD. And since this was a dominant circumflex, and visually definitely it was looking significant. So what we decided that we opened the strut with 2 mm balloon, and then we did a kissing balloon with 3 in circumflex and 3.5 in LAD, and we did a pot again, and then we checked the OCT pullback from the LAD as well as circumflex. So this was the OCT pullback, and this was the 3D navigation mode, as well as we also saw the 3D reconstruction. And on this 3D navigation and fly-through mode, we could see that there was no struts hanging on the LCX ostium, and in fact, so this was the post kissing balloon dilatation, and pot after pot we can see that the L6 carina was free, and there was a the L6 carina ostium was free of the struts, and we can see roughly a figure of 8 in front of the at the position of the carina. And then we pull back, we did a OCT pull back from the circumflex also, and we can see that the L6 ostium, we in fact measured the L6 ostium, it was around 5.5 to 6 millimeters square MSA at the ostium of the circumflex, and there was no significant, there was definitely some disease after the ostial circumflex, which was around 2.64 MSA, but since it was physiologically insignificant, we decided we'll not go forward with any of the complex strategies, and patient was hemodynamically stable, so we just left it. And this was the ostium of the circumflex seen on this 3D fly-through mode as well as 3D navigation mode, where you can see the ostium of the circumflex having a good ostial MSA without a strut hanging in front of the ostial LCX. So this was the final picture. Definitely the ostial circumflex is looking better as what was seen before. And this is the point we just stopped the procedure and the patient was hemodynamically stable. He was shifted to CCU. So to conclude, in the provisional stent strategy, the side branch pinching, the so-called visual optical side branch pinching, it appears to be significant, but it could be because of shadow of the main branch stent. And whenever there is absence of TME3 flow or whenever there is absence of dissection, we should always assess this, these so-called optically side branch pinched with a physiology and probably a combination of imaging. If this would have been a normal side branch, we would have just left it alone. We would have not dilated or did a kissing balloon. But since this was a dominant circumflex, we went ahead and did a side branch strut opening followed by a kissing balloon dilatation. The new modalities like imaging, especially the OCT-based imaging modalities like 3D reconstruction, 3D navigation and fly-through mode are very, very useful, especially when we are doing a bifurcation stenting or we want to see the side branch MSAs and our wire, whether it's passed from the proximal or distal stents. It's a very useful advanced techniques in OCT to assess, especially when we are doing a complex bifurcation or bifurcation techniques.
Actually,
Thank you very much.
if you see the first run of the OCT, the left main, that is not minor. It's a major malum question. It is more than 30% of the, if you take the area, even if you measure the distance between the stent struts and the wall, it will be more than 300 microns. If you leave that malum question, what happens? When you do the next time procedure, or if you are passing the wires, most of the time wire can go abdominally. That lead to LSD. And this can lead to shortening of the stent. Once the shortening of the stent takes place, it's very, very difficult to pass the wires. You will have a very tough situation. That's the reason before doing anything, if you see that malposition, good apposition with good size pot balloon is mandatory. There's a very significant malposition. We cannot leave that kind of malposition.
So we had done pot actually, in fact, before even passing the wire.
What I meant to say, the terminology, it should not, we should not label it as a minor. It's a major malposition.
Okay, fine. Yeah, exactly. But we had done pots, sir. We had done pots 2 times. Sir. Yes, sir. I agree with you, sir.
The size of this circumflex, you think, in the proximal part? Quite big circumflex.
Yeah, it's a big circumflex. But
And,
yes.
And you dilated with a 2 millimeter balloon.
Initially, just opening the strut with 2
2 millimeter
and followed
balloon,
by a kissing
and
balloon.
OCT showed that stent strut is totally opposed. Tell me, explain to me how it happened.
So initially, we opened the strut
You
with...
used larger balloon for kissing.
Yes, we do.
What is the balloon for kissing?
So it was 3 mm in circumflex and we used 3.5 in LED.
Yeah, still it is undersized.
Yes, exactly. It's,
But you don't want to do one-to-one. Obviously, I think because the stents, you can't see the left circumflex ostium is about 5 millimeter, 4 or 5 millimeters. So, but there is a good opening. So I think 3 millimeter balloon.
Millimeter balloon or 2?
For kissing, we did 3. Kissing, we did 3 in circumflex and 3.5 in LED.
That explains it.
Yeah, yes, sir.
But
Initially, opening the struts, we initially used 2 mm.
Thank you.
recent data suggests when you do the kissing of the side branch with a significant block, always go with the DEB. That is a side branch, long lesions, diffuse lesions. These ISL is the ideal indications.
We'll call
as per
the-
considered.
Yes, sir.
Thank you.